Hmm.
Yes. Thank you so much. It's the first beautiful day in the Maryland area, and I needed
Right
some
out
vitamin
there.
D. So I'm taking this outside. Hopefully the sound of the lovely birds chirping isn't too loud. Please let me know if it gets distracting.
Right. No, it's a beautiful setting and it's good to see you as always.
Yes, you as well. I want to jump right in as I know we have attendees who are eager to hear about our topic today on postpartum psychosis. Um, and I'm just and I think it's a great continuation of the discussion we had at our last webinar on bipolar disorder. So before we launch in, I'll give the introduction. Thank you everyone who's joining us for our Seven Starling webinar series. Um, for those of you who have joined before, you may know that this is designed to give you healthcare providers across specialties pearls to help you feel more confident in supporting your patients with mood and anxiety disorders across the lifespan of women's health. My name is Nazanin Homofar, and I'm a practicing OB-GYN in Northern Virginia and the medical director of Seven Starling. Seven Starling is a virtual mental health clinic that treats those experiencing anxiety, depression, and trauma throughout fertility challenges, pregnancy loss and miscarriage, abortion, and postpartum. And I'm honored to be joined by Dr. Crystal Clark. She is an associate professor of psychiatry at the University of Toronto and associate head of research at Women's College Hospital. She's dedicated her career to reproductive psychiatry and the advancement of maternal mental health. And not only is she a researcher, educator, clinician, and thought leader, we're also very lucky to have her as an advisor to Seven Starling. So today we're going to discuss postpartum psychosis and dive a bit deeper into risk factors, screening, and management. Thank you for joining us, Dr. Clark.
Thank you for having me.
I
Very
know,
important discussion, so I'm looking forward to it.
absolutely. And I think hopefully all of us will walk away with a few pearls that we can keep in mind as we continue to see patients. I know in February, when you spoke to us about bipolar disorder, I recall that one of the learnings that stuck with me most was that patients with bipolar disorder are 100-fold more likely to have psychosis postpartum. And sadly, only days after our webinar, the headlines were flooded with news that an L&D nurse in Massachusetts had taken the life of her 3 children and attempted suicide with a presumed diagnosis of postpartum psychosis. We now know that this nurse had actively been evaluated at healthcare facilities and engaged in social media to discuss symptoms of postpartum anxiety and depression, and even disclosed suicidal ideation. Um, can you tell us, and every few years, I know we hear about one of these cases, and we know that there are several cases, especially in women of color, that go unreported. Um,
Yeah.
can you tell us more about postpartum psychosis, how common it is, and what the risk factors are?
Yeah, so the common statistic is it's 1 to 2 out of 1,000 postpartum women. In fact, I don't even know that we have the best estimate though, because when we look at studies that have looked at inpatient admissions, the rate is 0.25 to zero point 0.6 out of 1,000. But of course, that doesn't include the people who present outpatient and never go to the hospital, or the people we never hear about, right? Who were never
Yeah.
diagnosed, such as, the woman, Lindsay Clancy in Massachusetts. So definitely plenty of people go unnoticed, unfortunately. And so we don't have the best statistic, but it's rare. The point is that it's rare. It's not a very common illness. We don't believe it's greater than 1 to 2 or 3 in 1,000 women postpartum. And it's an illness when we think about, postpartum tragedies, it's most often related to postpartum psychosis because that is the one emergency in the postpartum period that is mental health related, that if not treated, if untreated, and unchecked, it can lead to infanticide, can lead to
Mhm.
unfortunately, um, you know, taking the children's life or even taking their own life. So,
And how would someone present?
yeah.
What are the signs and symptoms that you might see in
Yeah.
a
So
patient?
this is always a hard one. So I thought what I would share with you all today was a couple of snippets from an article called Postpartum Psychosis, Madness, Mania, and Melancholia in Motherhood. And this was in JAMA, actually not JAMA, the American Journal of Psychiatry, so our Green Journal, which is the premier
Mm-hmm.
journal. And so it's, yeah, so it's the premier journal, but it's also written by a few of our top experts in the field. And I thought they did a great job of trying to bring this home because it's really hard to capture the symptoms sometimes. So I'm going to read about a patient with first onset postpartum psychosis with depressed features. And this is coming from the assessment of the patient. So the patient is well dressed, impeccably groomed, professional woman who comes to the clinic saying that she is depressed, but no one believes her. In response to a question about unusual experiences, she responds in a matter-of-fact manner. Inside me is a dark force. If you saw me when it comes out, you would see a dark shadow that looks like me outside of me. It is black, but you can see through it and put your hand through it. The shadow takes over me and makes me do things. Yesterday, the shadow made me put a pillow over the baby's face, and I might have suffocated him if my toddler hadn't pulled my pant leg, and alerted me to make the shadow go back inside. When I feel the shadow coming out, I walk outside on the porch with the baby and my daughter. If I kill myself, will the shadow go away? It's also notable that this was in January, so this is in the middle of the winter. And this is by Veerle Berging, Natalie Rascon, and Kathy Wisner. So I highlight that little excerpt to say it doesn't always present in a way where you're just like, oh, that's obvious. This is postpartum
Mm-hmm.
psychosis. This bizarre statement, yes, is supposed to be alert you to, okay, something's wrong. And she's talking about this dark shadow that made her put the pillowcase over the baby. So that's the delusion. And often it presents with these very bizarre things. We had a patient who tragically took her life postpartum, but she believed that the house was too cold for the baby. So she had turned the heat up to like 90 degrees. She just, she didn't believe that the baby was warm enough. She kept feeling that it was super cold in the house. That was part of her delusion, that somehow she was harming the baby because it wasn't warm enough. And the husband's like drenched in sweat. Unfortunately, he took her to the hospital. That no one thought anything was wrong with what he was describing and what she was saying. And she was, discharged and unfortunately ended up taking her life. So I say that to say it can present mainly with delusions, but the delusions aren't obvious. It's not like they're saying, oh, aliens are talking to me. They often actually don't hear, have auditory hallucinations, not in the classic sense anyway. It's often a change in cognition. So they almost seem delirious. And you might think, oh, they're sleep deprived. No, they seem delirious
Mm-hmm.
for no reason. And sleep deprivation is not it. And they seem less cognitively with it. Like they're having a hard time processing their thoughts, saying, picking the right word. They're just out of it, almost spaced out. Insomnia is another one in which they may not be sleeping at all, maybe up throughout the night. That could definitely be an indicator for bipolar disorder as well. But insomnia is also a one of the key symptoms. But you might have a patient who doesn't. I mean, they might describe a dark cloud, they're sleeping, but they're otherwise feeling fine. And of course, delusions is a major one.
And we'll talk about delusions, and I have a question about that later. I mean, it's so hard to hear all
Yeah.
of this because you think, um, we're used to picking up on cues. We're used to being able to notice a pattern. And I sent a link out to an article in the New Yorker where the author described how very normal
Yes.
the mother was presenting. She built a
Mm-hmm.
snowman earlier in the day. She asked for her partner to go pick up some medication. And so
Yeah.
I think this is where later on too, I want to talk about like, what can we, how are we supposed to then find something to then address, and how do we address it?
Yeah. It's a great question. And this is where really, this is not something we're doing yet. So I understand when I say this, people are going to be like, well, is it practical? But I think we've got to change how we approach care for this patient population, meaning that if they have a partner, a family member that can come to that appointment, that 6-week appointment or whenever it is postpartum, having someone else come and share, how they've been doing, along with asking the patient, of course, because sometimes they don't even have the insight to share with you. They can present very well, but even short of that, short of anyone coming to give you kind of a second set of eyes, so to speak, and what they've been observing, it's just, there really needs to be at least a few minutes to really ask the patient how they're doing. It's not going to come up on the EPDS. It's not going to come up on the PHQ-9. You really need to say, like, how are you doing? Have you had any worries about the baby? Ask a few questions and get them to talking. And they just naturally, when they're delusional, they're not thinking their thoughts are wrong. So they're likely to share just a random delusional thought. And if it sounds bizarre, that's a red flag to be concerned and to do further investigation, in which case you're calling your psychiatrist in your system or taking them to the ER, or you definitely have to at least dig deeper to see, okay, well, what do you mean by the dark shadow? Or what do you mean the baby would be better off without you? Or little statements like that could actually have quite significant delusional meanings to them. So.
Mm-hmm. And so one thing I always love about our conversations are how you model how we can ask questions, especially when we don't know these conditions that well as other providers. And so you're just taking what the person said and reflecting on it. You don't
Exactly.
have to know much more. You just say, so tell me a little bit more about that dark shadow, or why do you think the baby's cold at
Yeah. Yeah. Well, what is
92
the
degrees?
temperature in the house? So, how
Mm-hmm.
it's like, well, it's 90, but it's still too cold. Okay. I mean, just those little questions and likely that follow up will give you enough answers where you're like, yeah, I'm not feeling comfortable. Your gut
Mm-hmm.
is starting to react to the responses. I had a patient who thought the baby was going to get up, get a knife from the kitchen and kill her. I was like, oh yeah, no, that's, but that just came from, again, it wasn't the EPDS or the PHQ-9. That was me saying, well, how are things going? Or no, she was like, yeah, so I've been doing okay. I'm stressed, whatever. But I've been having these worries. I'm like, well, what are the worries? It takes a little bit of time. I can't say that it's, that you're going to get there in a quick 60 seconds, but even 5 minutes, you can learn a lot about what's going on
Tell
with
me,
you.
and because I want to go back. I want to make sure we provide the framework too before we talk about telling the
Mm-hmm.
difference. But what are the biggest risk factors for postpartum psychosis? I know we mentioned bipolar disorder. Is there anything else?
Yeah, definitely a history of postpartum psychosis before, of course. Those are the main two, but just honestly, being postpartum is a major risk factor for psychosis. It is 23-fold risk factor in the first 4 weeks postpartum for a psychotic episode compared to any other time in a woman's life. So, new onset psychosis, because you're schizophrenic or have bipolar disorder or any other condition or, substance use, whatever. Postpartum is the most high risk time for developing a psychotic episode.
And I mean, I just think about our current framework for postpartum, and nothing is set up to support it in a way, especially when we know that like 40% of people don't come to their postpartum visit. Um, is there anything, if a patient comes in and is worried with the headlines, um, and has questions about what they can do to prevent it or what they should look out for, what would you tell them?
Yeah, I would tell them definitely. I'm always encouraging to get a person that is, um, their partner, if they have a partner, if not a friend, a parent, a sibling, to educate them too on this, and to be around that person enough that they can check in and see how they're doing, because it's not always clear that the person with postpartum psychosis is going to have the insight. Um,
Mhm.
the woman in Massachusetts was sharing things, but I wasn't following her on Instagram, so I can't say for sure if I was following her, would I have thought she had postpartum psychosis, but it doesn't sound like anyone was alarmed by the things she was saying, despite her expressing her even feeling suicidal. Yeah, so, and it doesn't sound like she was saying, I'm having, these thoughts to kill
Sure.
my children. So it doesn't, it's hard to tell them to say this, or, to look out for that. But I would tell them, if they're feeling, you could still explain that if you start to have thoughts about not wanting to live, or feeling like your children will be better off without you, or feeling that something is wrong with the children, we should talk about it. But I think a family member being able to advocate, or a loved one being able to say, yeah, she's not acting quite like herself, something's off, is going to
Mhm.
be probably more helpful than the patient having to do that all alone. Because they show up to the ER all the time, and they're just not asked the questions that they need to be asked.
Yeah. And you're making me, usually postpartum, I've actually liked it when my patient has come alone without the baby so that they can have a little break. But it's actually changing kind of how I think about, especially for my high risk patients, the ones that have a history of a mood and anxiety disorder. Maybe even saying, like, maybe consider bringing a support person
Yeah.
to that visit to be able to get a little bit of insight or talk about support. Um, you talked about intrusive thoughts and then versus delusions. How do we tell the difference as clinicians, and how do we counsel our patients about the difference?
Yeah. And I just put that link into to answer the link for that article.
Oh, thank you.
But yeah, in terms of delusions versus intrusive thoughts. So intrusive thoughts are repetitive, what we call ego dystonic, meaning that you're not in agreement with what the thought is. Like, so the thought might be, I'm going to throw the baby, but you actually don't want to throw the baby, but you keep having the thought that you're going to throw the baby. So it's a
Mm-hmm.
repetitive, intrusive, ego dystonic, usually annoying, it's bothersome type of thoughts. Whereas the delusion is ego syntonic, like they believe, like, no, this is true. They believe I need to throw the baby because that's going to save the baby.
Mm-hmm.
Often the things that are tragically done to children in the context of postpartum psychosis are altruistic. The mother really believes that she's doing something that is going to ultimately help the baby. Maybe it's the baby's going to join her in heaven. The baby, if I do this to the baby, it's going to be cured of an illness. So they truly believe that it's not just a thought that's popping into their head, that they're thinking, why am I thinking this? People that are having
Mm-hmm.
intrusive thoughts will tell you, I don't know why, I don't want to do that. I don't have any idea, any desire to kill my baby, but for some reason I keep having this image, or I keep thinking about it, and it's really scaring me. They're usually scared of
Mm-hmm.
their thoughts, and they can articulate that, and they often are embarrassed by them. They don't usually want to share because they're fearful of consequences or something. But I always level set and say, so lots of women have very bizarre thoughts, and give some examples. And usually that kind of disarms them and lets them feel comfortable to share.
That's a great point of distinction. And I will say when I was postpartum, I had intrusive thoughts and it was deeply uncomfortable um and felt shameful at times too. I mean, and I could call them intrusive thoughts, but I didn't ever want to put it out to the world what I was
Yeah,
thinking. And I would wake up and I'd have to like shake my head and say
yeah,
like stop thinking about it because um it was very bizarre. Does that happen to the partner, or is this something that's like shared
yes.
by all parents?
I don't know that anyone has done a study on the partners and how whether or not they have these intrusive thoughts. That would be very interesting. I would have to look. I'm not aware of any research on that though that has
I just
characterized. We're kind of behind on the partners. We're just now
Right.
appreciating that they that they that
That's
they
true.
have postpartum depression too. So yeah,
That's very true. How if you kind of mentioned this earlier, but if you had to pick some interventions to address the issue of postpartum psychosis, what would it be? I mean, I heard you say we have to rethink how we deliver care postpartum, but
yeah, yeah. So
what are
interventions.
some things?
Besides bringing the partner in early, and also bringing the patient in. And I think, so to your point, 40% of people still don't come for their postpartum visit anyway. So my thought is, why do we not have some type of program that's actually such that, here I am dreaming, I acknowledge it's a
Mhm.
dream, but home visits or something. There's a reason people aren't coming. It might not be accessible, transportation issues, trying to get the baby and the other kids together, all the things. And then it's 6 weeks. For some people, 6 weeks, they're back at work.
Mhm.
So, might there be a intermediate check-in, 3 weeks? Because this is an illness where the onset of symptoms is usually 3 to 10 days. And it's even more immediate for someone who has bipolar disorder. So that first month is when we want to see them. So 3 weeks, 4 weeks in before they've gone back to work, and whether that's in the office, and if they don't come to the office, can a nurse call them? Are they okay? Just
Mhm.
do we need to have a wellness check or something? But yeah, I think we've got to also start thinking about everyone does not have the same resources. They don't have the same maternity leave. How else might we access them? So I would love to see something where it's either nursing staff, social workers going out, just to get that early visit. And, it's not something that has to be done repeatedly throughout the postpartum year, but also checking in sooner. 6 weeks is too long for
Too bad.
this illness. Yeah.
The New Yorker article I sent out to everyone um, gave the case of a patient in the Netherlands who had postpartum psychosis, and it's just a world of difference in the type of support that
Mhm.
individual had. They had a home visit. As soon as the
Yeah.
delusions were recognized, the partner called someone.
Yeah.
Social workers came into the house. They
Mhm.
observed her. They took her to a facility where she was housed with her, where she could be there with her baby. And you and I have spoken about these dyad facilities
Yeah.
and how rare they are in the
Yeah.
US. And then she had a 9-month treatment program.
Yeah.
Um,
Imagine
it's,
that.
yeah, I mean, people have to fight to figure out how to get into care here. And then there was another study that showed that the amount of parental leave for the birthing parent correlates with the rates of perinatal mood and anxiety disorders. So in places that have paid leave that is longer, you have lower rates of PMADs.
Yeah. No.
Um,
And it makes sense, right? I mean, it makes sense to me anyway, because part of the issue is the stress and the lack of support. And when you're feeling like I can take the time off and
right.
get support, it's like, oh, okay, I'm not as stressed. yeah, it's a completely different experience. But yeah, and it's funny you mentioned that from the article. I didn't read that particular article about with the Netherlands piece, but clearly I've listed all those things. It's like, yes, if we had
Yeah.
social home visits, having the partner involved, most partners wouldn't know who to call. They would be like, and having information, I feel like partners need to be at the at a third trimester visit, at least.
Hmm.
They can get some education. What does postpartum depression look like? What might postpartum psychosis look like? What do you need to know? Everyone's not going to receive it well. Some people are still like, mental illness is not real, but at least
Hmm.
give them information and who they might contact should they become worried about their partner.
Absolutely. And you remind me again the importance of birthing education.
Mm-hmm.
So few patients in the scheme of things in the US actually seek out additional birthing education resources to prepare for labor, to prepare for childbirth,
Yeah,
mostly because we make people pay for it.
yeah.
But that would be, that I think too would be a great way to introduce the topics as well. And I want to get to some of the questions.
Yeah, yeah.
One of one of my questions was going to be, what should an OB-GYN do if they're worried their patient has postpartum psychosis? And one of our attendees asked, how likely are clients to follow advice on hospitalization if that is necessary? Are you voluntarily, like, are these patients going to voluntarily commit themselves, or are they going to be involuntarily committed?
So in my experience, none of them want to come in. Like, but we're making judgment calls, to be honest, about whether or not they cannot come in the hospital once we recognize what's happening. So I'll give you scenarios in which I haven't committed someone involuntarily. And it's usually because I've been able to talk to mom, husband, sister, and I'm saying, this person cannot be left alone. Are you guys equipped to take off time, split time, whatever you need to do to make sure while she's going through treatment, she is not left alone? And then I like really bring it home. I do the Andrea Yates case. I'm like, that's what her husband was told. And then he left her at home. And in that 2 hours while he was gone and the mother was was on her way, she killed 5 of her children. So I remind them of that. And then we have a really heart-to-heart discussion about it. And if there is any suggestion that they're not sure if they're going to be able to do that, or they don't think they can, or they don't believe that she needs that much care, then I'm left to make that decision. But sometimes family will be like, oh, absolutely, we can handle this, we'll make it work, I'll be there with the baby. And that's,
Mhm.
yeah, we work that way.
That's great to know. So involving the support as soon as possible. And I'll say also for our attendees, this is where it's also great to get a name or two of your support. I always like to ask at the prenatal visits, who's in your support? Who are
Yeah.
you going to be bringing in to help you? So you're not trying to figure that out in a crisis setting.
Yes.
You've identified some of those individuals earlier on.
Yeah.
Um, I'm aware of the time, but I also want to take the last comment,
Yeah.
where I'll read it out. In looking at the recent recommendations from ACOG about the 1 to 3 week contact and the 4 to 6 week visit, what are your thoughts on doing perinatal screenings? I've been starting meds and screenings earlier and more often. I'm from Massachusetts, where I was an L&D nurse before becoming an OB-GYN NP in NY, and have many friends who know the Clancys. This rocked my Massachusetts colleagues who knew them. The stories that people posted on the GoFundMe are exactly what we're talking about and how alone they
Yeah.
felt.
I definitely think perinatal screenings at that time are great. I wouldn't do anything before 2 weeks because they could be dealing with postpartum blues, and that might be a little more difficult to tease out. But 3 weeks is actually when I have my patients return for the first time postpartum. I want them at that 3 week visit. And I think, again, at 6 weeks is great, or 4 to 6 weeks is good as well. I don't think it's anything wrong with that. And I think as part of the screening, it must be some conversation. We just can't rely on the scales for everything, unfortunately.
I think that, and then would you, in the interest of recognizing how hard it is for some patients to get get appointments. Would you say that this should be reserved for the patients who you already identified at being high risk for having a mood disorder, or ideally everyone should be brought in at 3 weeks?
I was definitely we want to prioritize high risk folks, but I would not underestimate the potential for someone who's never seen a psychiatrist or even a psychologist to have a new onset postpartum psychosis, bipolar disorder, depression, all of that. You have a lot of people living under the radar. A lot of my patients are like, yeah, I mean, I was kind of type A. Yeah, I'm anxious, but it's never been a problem. Yeah, until postpartum, and then it's
Right.
like a huge problem. And there's all the signs that have been leading up to that, but they haven't, had a reason to seek psychiatric care. And to clarify, with the question from the audience, yes, screening antenatally, yes, because often depression, anxiety is onsetting. Antenatally, and then what happens is we see that increases the risk for postpartum to be even worse. So if we can address that, I forget the exact stats, but it's a significant amount who have onset well before postpartum hits. So.
Thank you, Dr. Clark. And also to everyone in the audience, I included in the chat a list of resources from Postpartum Support International on psychosis, as well as a study that's being done out of MGH that is trying to look at potential genetic components of postpartum psychosis. So something to keep in mind if you have patients that have a history and would be open to enrolling. Any other thoughts, Dr. Clark? I know I could stay on with you forever.
This is one we'll have to keep revisiting because it's an important enough topic, and we still aren't talking about it enough. A couple of things I would say. I would just add that I did not mention that irritability is another key symptom, which could also be present in anxiety and depression, but depending on the type of irritability and agitation, that is something to consider. Of course, mania can present and evolve into psychosis or be a part of the psychosis. I'm happy to see with the Clancy family how much support they got. I think that's already a sign that we are at least heading in the right direction because, over the years, there's been so much criminalization of this illness, and the fact that so many people have been supported the GoFundMe, I think is a sign that at least we're getting somewhere, and some people understanding that this is an illness and this is not something that we should be like, put you in prison for. Can't speak on all the legalities of this situation, but I definitely feel like we definitely got to have more empathy and try to help these women. And because it's, once she comes out of her psychosis, she's going to be very hurt, very devastated about what's happened.
Absolutely. And I want to highlight the work too of one of our mutual colleagues and another advisor to Seven Sterling, Dr. Susan Feingold, who has contributed significantly to the legal aspect of this. She has testified in court in various states on behalf of postpartum parents who had psychosis and committed filicide, so that they are not judged in the same way that someone else is who committed murder. So there's a lot of aspects, a lot of ways that we can touch how we can help support people who are going through mental health conditions. But I love that we get to come together every other month and talk about these issues and hopefully educate ourselves so we can help our patients. So thank you again for all of this information. And to the providers who joined us, we hope you found these 30 minutes engaging and informative. And just a reminder to you all, we are seeing patients in Texas, Virginia, Maryland, DC. We do not see patients who have postpartum psychosis. our platform is not going to be best suited to do that, just to put that out there. But we're very much committed to helping people navigate other mood disorders across the reproductive lifespan. We also accept many insurances, and if you want more information, you can always email us at practices@7sterling.com, or go to our website to learn how you might be able to we might be able to help you in your practice. If you like this webinar, please subscribe to our newsletter so we can keep you informed about future events. We aim to make these as relevant as possible to the providers who are seeing patients. So Dr. Clark will come back again, hopefully in May, with another topic.
Absolutely. Well, thanks for having me, as always.
Absolutely. Absolutely. Great to see you. Thank you, everyone, for joining. And I apologize for running a little late, but we look forward to seeing you all the next time. Have a good night, everyone.
Bye.
Bye.